Well, welcome back, and thank you for those who organised the coffee. It was a very good break to have. James Almquist from Essex, we'll be chairing this session together. Just to say that, well, I suppose, first of all, one of the great attractions of this meeting, is that we have national and international quality speakers shuffled and mixed immediately and in close contact with patients from everyday practice who are presented here as cases. And I really appreciate those two cases we had at the end of the last session. It just sharpens the mind hugely. So thank you to those who are sticking your necks out and presenting cases here. Always welcome. Do some more next year. And some of you have presented abstracts ready to present the cases, and there's no room and there's no time. And your abstracts are now being fielded online, which might make you think you've been a bit shortchanged because of all that work and who's going to look at it. So Karim tells me but in addition to the published programme, we have an option of an extra session over lunch here in the lecture theatre to discuss the abstracts which would normally be up as posters downstairs when you eat and are now being presented online. So if there are cases you'd like to hear about, or you want to spend half your lunch break in here listening to cases being discussed, if you've submitted abstracts and you'd like to discuss them, Karim, is that right? Over lunch in here. Thank you again for those who are presenting. So this next session is about calcium and parathyroid. Jeremy Cox is going to introduce us, first of all, with how to make a secure diagnosis. Is that easy? 95% of the time, I guess it is. So we're interested in the other corners. And then we'll have Professor Chen telling us about what might be seen as a forgotten disease. Jeremy, thank you.
So I'd like to thank Prof. Palazzo for asking me to talk on making a watertight diagnosis of primary hyperparathyroidism. Thank goodness it's not oven ready. The consensus guidelines for the management of asymptomatic primary hyperparathyroidism come from the international workshops. And this is the fourth, and it quotes, primary hyperparathyroidism is diagnosed by an elevated total calcium with PTH levels frankly elevated or in the upper half of the normal range. That's the important point. Note their statements on normohormonal primary hyperparathyroidism. Subjects with hypercalcemia and a PTH in the upper half of the normal range are physiologically not normal. And it's important to note that such non-suppressed normohormonal concentrations are entirely compatible with the diagnosis of primary hyperparathyroidism. So it seems that the diagnosis is very easy. But actually, calcium and PTH are not independent variables, and it may be better conceptualized if you use a bivariate analysis normogram. So this is from Sheffield Metabolic Bone Center, and over 6,000 patients who came up for DEXAs, and they were included for bloods, Z-score less than -2, vertebral fracture, or high rate of bone loss. So therefore, if you think about it, this group is biased towards finding diagnoses of parathyroid disease. Now, if you look here, the bivariant normal group is actually showing quite a lot of the time high parathyroid hormone levels. The hyperparathyroid hypercalcemia group is representing 2.7% of the population. That's the easy diagnosis. The normoparathyroid hypercalcemic group is representing 1.07%. And notice that sometimes the PTH levels are in the lower half of the range. And the hyperparathyroid normocalcemia group is representing 5.1% of the cohort. So a huge number of cases for us. So I'm just going to start with giving you a case. So here's a 38-year-old lady, YT, who was referred with a finding of hypercalcemia, having had acute renal colic. So she has a borderline elevated calcium, 2.61, and the PTH is in the upper end of the normal range at 5.8. But the 24-hour urine calcium creatinine clearance ratio is 0.089. And the total is under 5, which starts to ring alarm bells. So the question is, well, she comes with a diagnosis of kidney stones, and surely this is primary hyperparathyroidism. So is there a cause for the low 24-hour urine calcium creatinine clearance ratio? Well, I've highlighted in red. Firstly, EGFR is above 90. If it's less than 50, that could be a cause. She is vitamin D deficient at 34.5 nanomoles a litre. She's not on lithium or thiazides that might do this. So this is a nice series from Prof. Palazzo showing that vitamin D deficiency may lower the calcium creatinine clearance ratio in patients with primary hyperparathyroidism. And this is based on 118 samples from 97 cases. You can see that those with vitamin D deficiency, levels less than 25 nanomoles per litre, 25% of them have a calcium creatinine clearance ratio less than 0.1, whereas when vitamin D levels are above 25, this is only around 5%. So the first thing to do clearly is Vit D replete these people. This is from Detroit, and we know that African Americans with primary hyperparathyroidism actually have a lower calcium creatinine clearance ratio. And if you look at these two groups, you can see that actually they're very well matched. I mean, vitamin D levels aren't great in European or UK units, that's 40 nanomoles per litre, but they've got similar EGFRs. But the 24-hour urine calcium is a lot lower in the African Americans at 2.9 versus 5.6 in the non-African Americans. And the calcium creatinine ratio is 0.012 versus 0.015. So that doesn't seem like a very big difference. But that actually means that 40% of the African American individuals have a calcium creatinine clearance ratio less than 0.01. So you do need to bear that in mind. Well, there's only one randomized controlled trial. This is from Aarhus in Denmark, showing that vitamin D supplementation is safe and doesn't alter plasma or urine calcium levels. So there's no reason not to do it. They used a high dose, 2,800 units, and that actually brought the mean level over 100 nanomoles per litre, so good repletion. Parathyroidectomy occurred at 6 months, and these weren't borderline cases. So the ionized calcium was 1.4 and the 24-hour urine calcium around 10. And what you can see is that those who were treated with vitamin D in the filled circles actually had no significant change in either plasma calcium level or 24-hour urine calcium level compared to placebo. So you can relax, give your vitamin D repletion, and watch. So go back to our case. Our vitamin D repletion, we use 20,000 units for 12 weeks, and then we remeasure. Her corrected calcium is now 2.70. PTH has actually gone up slightly at 8.7, but that 24-hour urine calcium creatinine clearance ratio is still low at 0.0091. So she has a history of kidney stones, and you think, well, this probably doesn't fit particularly well. But what you've got to remember is that FHH is enriched in the normohormonal group. So it's going to occur about 4 times as often in the normal hormonal group, or maybe over about 5%. So this is a lovely, it was mentioned before how nice all the Scandinavian studies are. So this is a lovely one from Denmark, 2 university centers. And this is the results from 66 of their patients with FHH. And what you can see is that the PTH level is dependent on the mutation, but is generally, in 80% of cases, in the normal range. And if you look here, even in the lower half of the normal range, and is very rarely over twice normal. And this is more data from the same Danish cohort where they're comparing 54 FHH1 cases with 97 primary hyperparathyroid cases in the top. And they look at the performance of the calcium creatinine clearance ratio on an unrestricted diet. What you can see is that at the 0.01 traditional cutoff, you pick up 65% of the FHH cases. But if you use 0.02, you pick up 98%, only one being missed, but at the expense of picking up 35% of your primary hyperparathyroid cases. So mutational analysis is now available for 3 types of FHH, all autosomal dominant and all causing reduced calcium sensing receptor signaling. So this is from a Paris group looking at 220 suspected families. And what they see is in 60% of cases, calcium sensing receptor mutations, FHH1. In 9% of cases, they pick up AP2S1 mutations, which is responsible for the APT sigma subunit, which is part of the clathrin mediated endocytosis pathway and responsible for receptor recycling. So that's 9% of cases. No mutations were found in GNA11, and in fact, there's only one family reported in the literature with 2 individual cases, and that's part of the alpha 11 subunit connecting your G protein coupled receptor through to downstream signaling. And importantly, 31% of cases do not have a diagnosis. And so really important here is don't forget the basics. In fact, if you just had 3 first-degree relatives, you would have a higher pickup rate than the genetics. So you've got to do that and search out the previous bloods. Just find previous bloods from earlier in life. So luckily, Genomics UK GNAP is extremely generous, unlike anything else. So R151, familial hyperparathyroidism or hypocalciuric hypercalcemia, covers for the 3 genes involved in FHH. And she, our patient YT, qualifies both on this with a generous calcium creatinine clearance ratio less than 0.02 included, and they say normally with a normal PTH. But she also qualifies under familial hyperparathyroidism by being aged under 50. So the point about this is use it, because it's now available and it's a wonderful system. So in conclusion, an R220W mutation in the calcium sensing receptor was found, and she had FHH1. And I made this mistake. And so the lessons from it are perform your 24-hour calcium creatinine clearance ratio properly and repeat, particularly in normohormonal cases. A spot urine calcium creatinine ratio is simply not adequate. A history of stones or osteoporosis should not put you off the possibility of FHH. These are common disorders after the age of 50, and therefore they may just coexist. Use this generous genetic system, R151. There really is no excuse for not doing that any longer. And in recurrent normohormonal disease, it's particularly important to do the genetics. I've picked up several FHH cases this way, even though unfortunately that is not officially sanctioned. Luckily, it's very easy to quote family history. So I'll just take you through 4 pitfalls in this group. Beware that lithium usage causes an FHH picture with hypocalciuria due to a similar right shift in the PTH set point. So it takes a higher calcium level here on the x-axis to half maximally suppress your PTH secretion. That's acutely, but chronic usage then leads to primary hyperparathyroidism at the rate of 1% a year or so, according to the UK GP database. And 50% of these cases have multi-gland hyperplasia. And my advice here, and this is partly personal, is don't stop the lithium, because the serum calcium won't change very much. It won't reverse. And Prof. Palazzo has published on this. Lithium's actually anabolic to bone. It activates the Wnt pathway. So your fracture risk increases if you stop the lithium, partly, I think, due to psychological change in the patients as well. And finally, the urine calcium excretion will actually increase if you stop the lithium. So really, be cautious before you stop lithium. And then go for a bilateral exploration only if you meet the surgical criteria. So stone cases average about 23% in the surgical series, and that's the main criteria. And just remember, osteoporosis is not associated, okay? So Prof. Palazzo has also published on stone case numbers, and I just don't have the space, I'm afraid, to show all the data. Second, beware. Serum calcium levels are higher in FHH3, despite similar PTH levels due to reduced renal calcium excretion. So this is actually from the European group, and if you look in the FHH3s, they have a mean serum calcium of 2.85 compared to FHH1s at 2.62. And then this data here is from the Oxford group, and what they've shown is that in FHH3, there's a reduced calcium creatinine clearance ratio, 0.05 is the mean, and all cases are less than 0.01. And basically, you're reaching a new equilibrium because you've got reduced renal excretion, and that causes a higher serum calcium level. In fact, the Oxford group think there's only 3 mutations in FHH3, all affecting the same arginine 15 codon, and the level goes with the mutation type. Third, beware atypical FHH. That might present as or develop primary hyperparathyroidism. So there are many case reports of this in the literature, but they can be symptomatic. And in Raj's Thakker's FHH3 series from Oxford, 4 of 17 cases were symptomatic. They may have frank hypercalciuria. Big family from Sweden of 7 of 10 members looked at had high urine calcium excretion, and 3 of them had kidney stone. Other series show osteoporosis, and in FHH3, this seems to be enhanced. 5 of 10 cases in the Oxford series had a low bone mineral density. And you think, well, at surgery, you're going to find normal parathyroid glands, but actually parathyroid nodular hyperplasia was found in 7 of the 9 operated Swedish family, and an adenoma in 1. And so there is this concept that FHH might be predisposing to primary hyperparathyroidism developing, and we have certainly seen that. And I'm sorry I don't have time to show you a case we just had last week. And then just remember, you can achieve normocalcemia post-surgery. So 8 of the 9 from the Swedish family achieved normocalcemia. So Marx, who's probably the most famous person on familial parathyroid disorders, doesn't so necessarily draw a distinction. You know, they're coalescing entities, FHH and primary hyperparathyroidism. So just remember, they're heterogeneous, these syndromes. You should have a high index of suspicion in young people, and absolutely wait for the genetics before operation. It's a right nuisance. It's 4 months, but you really have to wait, okay? Next, beware. Estimates suggest up to 1% of cases of primary hyperparathyroidism have a low normal PTH, or even an undetectable PTH can be seen. So these are some of the cases, and these are all the surgical results were what was found. And the cases for the low normal are summarized by Wallace, and then from the Alabama group, Song et al. Have published a nice recent one summarizing those with an undetectable PTH. Okay, so the reason, first, you've got to say to yourself, have I just underfilled my specimen? Repeat it, okay? Second thing is my platform somehow got interfering antibodies? Has a person got interfering antibodies with the assay? So do it on a different platform. But sometimes it's actually the PTH molecule is abnormal. You might have a shortened mutated molecule, and so that's the case here in the OWL group. Just those are things you should be thinking about. But of course, you are not allowed to say this is primary hyperparathyroidism until you've done a little bit more. So in such cases, a workup to exclude other possible diagnoses is indicated, and you've got to do it. Thyroid function, thyroid fructosis, short synaptin for Addison's, serum ACE 125D, steroid suppression test perhaps for granulomatous, protein electrophoresis, urine BJP for myeloma, PTHRP for humoral hypercalcemia of malignancy, and then some imaging, CT chest abdominal, or perhaps an FDG PET for picking up cancers, and very rarely genetics for something like idiopathic infantile hypercalcemia, looking for 25-hydroxylase deficiency. So you've got to do the full workup. And in the Song paper, it's very nice. They show that a Calcet trial may be very helpful, okay? If you're thinking this is probably parathyroid related from the history and the longevity of how long it's been going on, give Calcet, see if the calcium normalizes, okay? And in the Song case, it normalizes, and at surgery an adenoma is found. Okay, so just think about that Calcet trial. And then finally, if I'm allowed another 5-10 minutes, I'm just going to talk on the hot topic of normocalcemic primary hyperparathyroidism. So this was first recognized in the 3rd international workshop in 2008. And in the 5th international workshop, this is the diagnosis required. So it's continuously elevated PTH above the upper limit of normal with normal calciums on at least 2 measurements greater than 3 months apart, with thorough exclusion of secondary causes. But really our problem is as summarized by Estelle, is the challenge is to recognize the clinical context in which PTH levels are measured in individuals where the calcium is entirely normal, I mean, who should we be measuring it in? And I'd say that probably just has to be problem-based, okay? You can't just do it in anyone. And Prof. Palazzo, as part of the NICE guidelines, they'd also say if your calcium was above 2.5. Okay, so if we go back to this great Sheffield study, normocalcemic primary hyperparathyroidism is actually seen in this group here to the right. Now, there were 319 cases in this group, 5.1%, and 308 had good causes for secondary hyperpara. Low VIT-D levels, less than 50, low EGFR, less than 60, hypercalciuria, as by the new definition, 6.25 or 7.5 in men in total over 24 hours, or interfering medications diagnoses. And at the end of this, they only came up with 11 cases of normocalcemic primary hyperparathyroidism, or 0.18% of the group. And that's actually pretty similar to community-based studies such as the Dallas Heart Study or the Mr. Ross study, where prevalence rates are up to about 0.6%. So don't get carried away by those enormous number of patients you see with a high PTH level. That's the real prevalence in a biased group, because they've been seen with low bone density. Well, we've known for a long time that renal stones occur prior to frank primary hyperparathyroidism being seen. So this is a lovely Danish cohort from 3 university sites, over 600 cases versus matched controls, and they've got great databases. And if you go back, the incidence rate ratio, 10 years before they're diagnosed and have their parathyroid surgery here, they've got 10 times the rates of kidney stones as normal. So what that tells us is that during the normocalcemic phase of the disease, they are at risk of kidney stones. It's a biphasic disease, and they're at risk before the hypercalcemia becomes evident. There's similar data from fractures, but I don't have time to show you. Now, normocalcemic hyperparathyroidism does not seem to be associated in this new recent study, which is very good, unlike primary hyperparathyroidism. So, this is a cohort from 5 centers in Rome, and it's retrospective, but they're very well worked up and documented, with exclusions for secondary hyperpara, and they've all had a DEXA with vertebral fracture assessment. If you look at the primary hyperpara, well, they have statistically lower phosphate levels than controls, statistically higher CTX, bone resorption marker, statistically higher P1NP, bone formation marker, and they have lower bone mineral density at the distal third radius, as you might expect, and also at the total hip, which I haven't put. So they are different from the control groups, and there is a markedly elevated risk of vertebral fracture, which is pretty well like other studies running around 2.5 to 3 times normal. It's an enormous percentage when you think about it. 60% of them have a vert fracture. So the normocalcemic primary hyperpara group, though, they run somewhere between the control and the primary hyperpara in all these parameters, and it doesn't hit statistical significance except for the phosphate. So what does that mean? I think Columbia University is the famous parathyroid center, and what they've shown is that continued normocalcemic primary hyperpara is a risk for worsening of osteoporosis. So this is their normocalcemic cohort. And what you can see is that at baseline, these are symptomatic patients. 60% have had fractures, 60% almost have osteoporosis. And after 3 years, almost 20% progress on the basis of going hypercalcemic for surgical criteria. But the 41% in total worsen over that time period. And this is important for the way we find these patients as well, our clinics. But that's mainly because they get new osteoporosis diagnoses or a greater than 10% decline at one of the bone sites, particularly at the distal third radius. So really, there is deterioration over time in the bone parameters, even if at baseline you cannot prove a bone phenotype, okay? So it's the ongoing risk which we're concerned about. And the great news is we know that getting our surgeons in there improves the bone mineral density in cases of normocalcemic disease versus a Paris cohort referred for osteoporosis. And what you can see is that in the normocalcemic group, 1 year post-surgery at the spine, there's a 2.3% increase in bone mineral density, and at the femoral neck, 1.9%. And compared to the hypercalcemic group, an increase of 4% and 3.2%. So statistically, these aren't different. But I suppose the magnitude, you might say it's small, but it's definitely there, and it's better than actually worsening. So the great news is that there is now actually a guideline to the diagnosis of normocalcemic primary hyperpara. And this is the 2021 European Parrot Working Group. The first thing they say is measure ionized calcium, but our nice guidelines, as told by our prof, actually tell us not to measure that. So we don't use ionized calcium, but there's good reason for that. We can argue. So the next step, I'm going to show you a case to take you through it, but the next step is exclude the following causes of secondary hyperpara. So just to take you through a couple. First, VIT-D, replete them. Okay, so 20,000 units over 12 weeks is what we do, and get the level over 75 nanomoles liter. Second, calcium intake. Well, make sure they've got a good calcium intake. 800 milligrams for a normal person. Post-menopause or osteoporosis, 1.2 grams. So supplement their diet with calcium supplementation, because that's going to help you make the diagnosis. Okay. And thirdly, the hypercalciuria, treat them with a thiazide, because again, you're going to make the diagnosis that way. So let me come onto a case to illustrate this. So she's a 55-year-old lady with a 10-year history of kidney stones referred by our urologist, Mr. Dasgupta, multiple interventions, including a duplex ureter reconstruction, no family history of stones. She has a corrected calcium of 2.55, PTH 16.6, low VIT-D of 32.5, and a 24-hour urine calcium just high at 6.39. So what's the differential here? Well, she could have secondary hyperparathyroidism due to vitamin D deficiency. She could have secondary hyperparathyroidism due to idiopathic hypercalciuria. But in truth, to me, that all seems maybe not quite enough. So work your way through their pathway as per guidelines, replete the VIT-D, and track the calcium. You or I, calcium levels don't actually vary that much. They vary by about 0.1, plus or minus 0.1. The odd thing about primary hyperparathyroidism is they vary a lot more. And they also vary a lot more in the normocalcemic hyperparathyroidism. So this is taking the Sheffield 11 cases, and look how extreme the variation is. It's all the way from 2.25 up to 2.75 in one individual. So what you just need to do is watch, track the calcium levels over time, and you will often pick it. And in this series, only 4 arrowed stayed normocalcemic, but actually 7 of those 11 cases became hypercalcemic over time if you just tracked. So especially with the British sort of UK NICE guidelines, where we're not measuring ionized, be patient, track the total calcium, you will probably get your diagnosis. But of course, we're not patient, so I'll tell you some more. So the other thing just to say is always do the appropriate workup. What you've got to think about is, what is the underlying disorder I'm trying to treat? You're thinking about normocalcemic hyperpara, but work them up properly for the underlying problem, the bone problem or the stone problem. So this is just her stone workup, which is as per the 4th International Workshop. And what you can see is she remains hypercalciuric, 8.10. And she remains having a high PTH with a high normal calcium. So this lady, she was quite impatient, and she liked the horses at Cheltenham, and so she wants to get out to her racing, and she wanted this all sorted. So we said, okay, we'll do an oral calcium load test. Now, I should show you our data, but which Prof. Tolley presented at Beats, but the oral calcium load test nadir PTH can differentiate primary hyperpara from normals. So basically, in the top here, you've got surgically proven primary hyperparathyroidism. And when you give them a calcium load, the PTH doesn't drop. Here you've got normals. You give them a calcium load, the PTH drops into the lower half of the normal range. The normocalcemic bunch are more difficult. They don't suppress into the lower half of the normal range. They stay about the top end, and they don't suppress generally by more than 50%, according to what we've found. But there's no study which has those all surgically documented to be absolutely gold standard about this. So the cutoffs are not well defined. So anyway, we say, okay, we're going to do a calcium load test on this lady. We bring her in at time 0. She gets 1 gram of calcium, and you can see that she goes markedly hypercalcemic. So that's a suggestive. A PTH does not suppress. It was still above the upper limit of our normal range. And the calcium creatinine clearance ratio at baseline is elevated, which suggests she has fasting hypercalciuria, a sign of primary hyperparathyroidism, although it could be a sign of renal leak hypercalciuria. So can we do another test? Well, treat the underlying problem. He's got stones, hypercalciuria. Thiazides have been shown to uncover autonomous parathyroid function. So this is a lovely study from the Mayo Clinic, which has actually been updated recently. But there's 72 hypercalcemics on thiazides. And in 33 who've discontinued, they managed to follow up 28, and 21 of them remained having intermittent hypercalcemia. So the thiazide had shown the underlying primary hyperparathyroidism. And the reason for that is that thiazides reduce calcium excretion by 50%, but also they actually increase PTH secretion. So what should we do? We get our case, we give her thiazides, and I measure at 2 weeks and 1 month and 3 months, and she goes nicely hypercalcemic, and the PTH doesn't suppress as she goes hypercalcemic. So you've got your diagnosis of normocalcemic primary hyperparathyroidism confirmed. Localization studies on her showed a left inferior pole adenoma, and she had a focused left-sided approach removing that. And she was part of Prof. Tolley's BEATS series. So in summary, repleted her with cholecalciferol, tracked calcium and PTH for more than 3 months, do a full stone and bone workup, whatever the complication is, as per clinical problem and the guidelines. You have an option for a calcium load test, and we've done a lot of them, and they can be very helpful, but they're not well defined. Start treatment for the underlying disorder. That is the most important thing. Treat them for why they come to see you. Give calcium supplementation in osteoporosis. Reduce the stone risk by using a thiazide, checking your calcium and PTH. And then localization studies, if your calcium load test is positive, if hypercalcemia develops when on treatment with a thiazide or calcium supplements, or if your serum calcium consistently is above 2.5 with a PTH remaining elevated. Okay? And so the Parrot 21 guideline, I'm not sure I totally go with it, but it says surgical intervention should be considered only if there are compelling indications and a surgical target. Well, certainly compelling indications, I would prefer it that they had a complication. Okay, a surgical target, well, I don't, we try to make a biochemical diagnosis here. And I see the Alabama group smiling, and that's because they wouldn't do any localization studies. And since their success rate in this is 91% compared to, let's say, UCLA, which is 64%, I would say that was probably the right approach. So I don't really like that bit surgical target there in your Parrot guidelines. But otherwise, I do think you should try and have a compelling indication. And in truth, I'm cautious if I haven't produced hypercalcemia, because I know if I've managed to produce hypercalcemia with proper treatment, then they've definitely got it. And if I haven't, you've got to be really sure of yourself. So just look after your surgeon, because as I said, there are series out there. It's difficult surgery, and there are series out there where it's as low as 60%. Let me just open on that a bit. If you do normal primary hyperparathyroid surgery, we know that 20% of patients still have elevated PTH levels, and that's partly due to hungry bone syndromes and things occurring after. Now, within normocalcemic disease, of course, the diagnosis has to be that the PTH is normal afterwards, as in the American guidelines, etc. So that's a hard task. So it doesn't surprise me that the Mayo Clinic series is 80%, because to me, 20% are going to have an elevated PTH afterwards. So I just think you have to bear in mind that this is not easy. And the definition of cure is also not an easy one. So please be really sensible before you refer these patients. Know you've got them well worked up and help your surgeon. So I'd just like to say thank you to the metabolic bone team who look after me. That's Alex and Priscilla. And and the three surgeons who do our surgery here, and we are just truly blessed because we have fantastic results. And also Mr. Dasgupta, who's a urologist who comes to my clinics. Thank you.
Jeremy, thank you for a fantastic presentation. I began by thinking this topic was fairly straightforward, and I'm wiser and less secure now as a result. Questions for Jeremy? I'll begin with the first one. We tend to think in binary methods, don't we? This is FHH. This is primary hyperparathyroidism. One can't mix with the other. And I remember a patient where I confidently diagnosed FHH and discharged the patient who got back into clinic. Somebody didn't read the notes. I'd said no more needs to be done. And they did it all again. And of course, they were right and I was wrong, and the patient was developing hyperparathyroidism. And so your suggestion that one can morph into the other is well taken.
But yes, they can present initially severely as a primary hyperparathyroidism type diagnosis, or they can morph into it. And it's tricky.
A question here.
Thank you so much. I wonder what you think the primary problem is in normocalcemic hyperpara, because you said the kidney stones herald the future hypercalcemia which they may develop. But
well, I just
think it help the calcium absorption from the tubules. So is it maybe a primary problem in the kidneys?
Where is the problem? No, I just think it's a biphasic. I think it's simplest to think of it as a biphasic disease. You've got a normal calcemic phase when complications are happening because of the PTH.
If you've got normal calcium in the blood, why are the kidneys not absorbing enough calcium with the raised PTH?
Well, I didn't
prevent kidney stones.
Well, that's really interesting, but I didn't show you the data there. But actually, if you look at the normocalcemic group, the 24-hour urine calcium data is not statistically significantly different from controls. So yeah, you're raising a really interesting question. They still get the kidney stones as it's developing, but at that point, their 24-hour urine calciums are not high. Yeah, so that's a really interesting question. I don't have an easy solution.
Can I ask about 2.2 to 2.6, the quoted normal range for calcium? You say that the individual calcium is very tightly controlled. So the scatter 2.2 to 2.6 is probably a population scatter rather than the range of physiology for an individual person. And so somebody who lives at 2.3 and now goes to 2.5 still appears black on the screen rather than red on the screen. Would you think that is a significant change?
Yeah, so it probably does hold that if you knew your prior calcium levels, that would be helpful. But yeah, that's an awful ask.
Well, if you live in a place where data are stored locally for a long time, you can flick back and see what the calcium was 10 years ago sometimes when a patient first comes to clinic.
Well, it is very helpful in working up our cases and in excluding FHH by looking right back. But yes, their variation that develops is a tricky one because they really can be as low as they were before or go very high.
Hey, Jeremy, excellent talk. We've just got a couple of questions here online. I think they're more practical questions. So there's one about monitoring patients with normal calcemic hyperpara. I'm not sure whether it's pre or post surgery, but any...
Well, the first thing I always do is give the GP advice. I tell the GP to give them calcium supplementation, give them vitamin D, measure again in 12 weeks' time. And if the PTH still remains markedly elevated and they can't think of another reason of secondary hyperparathyroidism, then they're allowed to re-refer. I'm quite strict. And also I quote the NICE guidelines and I say, actually, I would prefer the calcium to be above 2.5 because actually that's where we know we will have a much higher rate of pickup. There's a lovely Swedish breast cancer cohort where actually over 2.5, there was an extremely high rate of pickup of primary hyperparathyroidism. And I expect that was used in the NICE guideline, the Lundgren's article. Right.
Can I follow that question with asking about FHH? Should we follow them long term or diagnose and discharge? Give me a wave if you think you've generally in the past done diagnosis and discharge. And give me a wave if you've always in the past been cautious and thought, oh, we'll just hang on to this to see them once a year and just check. Nobody. But maybe,
Well, I was really hoping Jeannie was going to put her hand up there. But let me say, I mean, my feeling on that one is fine. You don't think they're going to get kidney stones, but what about a serum calcium of 3 in some of your HH patients? Isn't that going to burr up your arteries a bit? So I'm a little bit concerned. You know, I don't know that calcium sensing receptor is playing a major modulating role in your arteries. It might be bone and your kidneys, but it's not in your arteries. So I'm a little bit suspicious that there might be an end vascular problem here. But I know I'm probably way out here, but I sometimes keep them in clinic if they're over 2.85 above that surgical. I'll keep them, do a CTCA occasionally, make sure they're not developing cardiovascular risk factors, and be a bit sensible. But it's individually determined.
I can imagine that Hammersmith Hospital Symposium, multiple disciplinary endocrine symposium from 2027. Do you remember that one? Or was it 2028? Where they said, oh my goodness, all these FHH patients, you should have followed them all along because don't you realize there's a new story coming out here? That's the future, of course. And you wish you'd kept them.
But the thing is, there's a treatment for them as well. So if they've got severe hypercalcemia, we know that cinacalcet will work just as well in them as in primary hyperpara and will bring down calcium levels. So I think, you know, the point is there is a logic because screening them, continue to watch, and then you actually do have a treatment if you feel.
Non-binary thinking.
Maybe last question, Jeremy, before you go. Advice on calcium and vitamin D for normal calcemic hyperpara. That will be the last question.
Okay, so you're trying to treat the underlying complication and you are trying to precipitate presentation of hypercalcemia. So gram a day of calcium, 1,000 units a day of VIT-D would be very standard type of thing we'd think of. But we actually use a VIT-D repletion course to track in clinic.
Okay, so it gave me great pleasure to introduce our international guest speaker today, so Professor Herbert Chen. So there's a lot to say about you, so just I'll summarize a little bit. So Dr. Chen is a leading endocrine surgeon, internationally known, especially for pioneering the radio-guided parathyroid surgery. He is currently the chair of the Department of Surgery at the University of Alabama in Birmingham, and he's also the surgery-in-chief there. So he's got lots of research interest, which span across thyroid, parathyroid, adrenal surgery, and many others. And today we'll have the pleasure of having him to give us a talk about hyperparathyroidism, the forgotten disease. Thank you.
Thank you, Herb. I just want to say one of the great privileges of being a doctor and a surgeon is this creating a fraternity. And we've had you here as our guest of last week, and it's been absolutely fantastic for you to bring your team, and so we are looking forward to you. You do realize you're only the second American that's ever spoken. The other was Ian Hayes. So
oh, wow.
And he's Scottish.
Yeah,
So,
that's true. That's true.
Thank you very much.
No, thank you so much. And we've had a fantastic time here. None of us in our group have ever visited the Hammersmith, and I remember asking Amy and Faust if we could come visit you when we were at the international endocrine meeting. And so we're so excited. We've been here since Monday. And we've had the great opportunity to learn from them, watching them in theater and in the clinic, as well as a research conference we had yesterday. So on behalf of all of us, I wanted to thank you for having us. And we have a gift for you guys. So Sophie's going to bring it down. So one of the things we do at UAB in Pharm Surgery is we barrel our own bourbon. So you have a bottle here of UAB surgery bourbon. It is actually our 10th barrel. So that you'll have to. Yes, well done. Oh, no worries, no worries. I don't know about that. All right, and I want to thank Jeremy for a fantastic talk. It makes my talk a lot easier because it sets up definitions and everything, and it gives, again, a surgical viewpoint on hyperparathyroidism, which I often refer to as the forgotten disease, and you'll see why. So I did want to tell you a little bit about where we're from, the Birmingham in the USA. So UAB is one of the largest academic medical centers in the United States. We're the largest employer in our state of Alabama, having an economic impact of over $12 billion in our state. We're a very diverse school, and for 4 years straight, named a diversity champion, and we're in the top 10% of all universities globally for research per U.S. World News. A little bit about our department. We have 154 faculty, and I've got to recruit 118 of them, which has been great. We have 9 divisions. We do almost 60,000 operations, over 80 operating rooms at our institution. We have 5 residencies, 11 fellowships, and one of them is an endocrine surgery fellowship. We have many pipeline programs, and we were ranked as high as number 10 for NIH funding in the United States. So I won't have to dwell very much on hyperparathyroidism because Jeremy gave us a great talk. But these are statistics in the U.S. about how many patients we see with this disorder. And it is the most common endocrine disorder after diabetes and thyroid disease, and the number 1 cause of hypercalcemia, both outpatient and inpatient. So these are the U.S. numbers, or the numbers at our institution for our units of calcium and PTH. And clearly, based on our units, patient number 1 clearly has hyperparathyroidism, both hypercalcemic and elevated PTH. And in surgical literature, you'll see these are often referred as classic hyperparathyroidism. But the types of hyperparathyroidism, which Jeremy also talked about, the normal hormonal in patient 2, and the normal calcemic in patient 3, which, as he said, after a thorough workup of excluding everything, to making sure they don't have secondary causes, could have hyperparathyroidism. But patient 2 and 3, often in the surgical literature, are referred as patients with mild hyperparathyroidism. But I'll show you some data that they don't really have mild disease, but just mild numbers. So why should we treat hyperparathyroidism? Although almost all of you know, there's a lot of reasons why. Certainly for renal function and bone density, a lot of data on that. And there is more and more data about how it improves quality of life and resolves the symptoms of hyperparathyroidism. And at least the patients that we see have a lot of symptoms from hyperparathyroidism. And this is a survey we did in our patients with the most common complaint, if you question them carefully, will be fatigue by far. And what happens to these symptoms? Well, they definitely go away when you do surgery, but some of them take longer than others. Fatigue probably taking the longest. But interestingly, if you look at 6 months, almost all of these symptoms have improved by that time. There's been a lot of quality of life studies, and the reason I highlight the one we did when I was at the University of Wisconsin is because I think it was an early study which looked at patients with mild hyperparathyroidism. And what was striking in this study, we used an SF36 survey given to patients both before surgery and a month and 6 months after surgery. And we looked at their quality of life measured by the SF36. And the first 8 are the different parameters, and then the composite physical and the composite mental are at the end. Well, what you'll notice right away is that all the bars are positive, right? All the patients reported improvements in their quality of life, with a dark bar being the classic patients who have both elevated calcium and elevated PTH. But what was really striking in this study is that the patients with the mild numbers reported the greatest improvements in quality of life across all domains. So that was an early study that we did, really pressed upon us that these patients really have a lot of symptoms that will improve with surgery, and if you question them carefully. And there's been a lot of work showing that it improves quality of life with regard to sleep, heartburn, pain, and some neurologic symptoms. Now, there is a lot more data emerging that actually treating hyperparathyroidism can reduce psychiatric complications. And with the emergence of the number of psychiatric patients with psychiatric disorders being diagnosed more commonly. So this is a study that our group did, led by Song, one of our fellows, where we looked at patients treated at UAB, almost 4,000 patients, and we asked the question, if you look at patients with hyperparathyroidism and compare those who had surgery versus those that didn't, what was the risk of neuropsychiatric disorders afterwards? So these are the cohorts, propensity matched. So we looked at almost 2,000 patients and half having surgery, half not having surgery. And these show the pre-existing neuropsychiatric symptoms, the percentages, and the new onset neuropsychiatric symptoms. And so in this study, we demonstrated that patients who underwent surgery had reduced incidence of cognitive impairment, somnolence, schizophrenia, and they were less likely to require inpatient psychiatric care for neuropsychiatric disorders versus those who did not have surgery. In fact, it was 9 times less. So pretty significant. But importantly, we wanted to make sure that these weren't results that necessarily were reflected only UAB patients. So Julia, one of our research fellows, used the TriNet X database, and that is an international database which many institutions contribute to, including UAB. And if you're one of those members, then you get access to that data. And Julia just presented this at the American Association of Endocrine Surgeons meeting earlier this year. And using this database, which contained, for this study, over 15,000 patients, and again, compared parathyroidectomy to non-surgically managed patients with hyperparathyroidism. She also showed that patients who had surgery had a reduction in anxiety, depression, bipolar disease, cognitive decline, and somnolence. So hopefully, and there's other data from other institutions showing this, so hopefully I'll present to you that I think that there's a potential for parathyroidectomy to reduce psychiatric complications as shown here. So what about survival? There has been debate about this topic over many years, and starting with the studies from Scandinavia, showing that potential survival when you look at population, and this data is old, but when you look at overall death rate in men and women with hyperparathyroidism, it has increased, primarily due to cardiovascular death. And in Denmark, studies showed that patients with hyperparathyroidism have a 2.5 relative risk for MI that is reduced to normal 1 year after parathyroidectomy. But what about more recent data? So this was a study done by Kim Remenel, who was one of our fellows at UAB and now is at University of Pittsburgh, where we worked with the group at Columbia, James Lee and colleagues, to look at a population of patients from New York and California over a 2-decade period. And how we did this study is we looked for patients who had hyperparathyroidism and nephrolithiasis, and looked at what is the cost if you delay parathyroid treatment for more than 2 years for both your kidney disease and your heart disease. And this was published in the Annals of Surgery. But delaying parathyroidectomy for more than 2 years increased the risks of stone retreatment by 60%. But it also increased the risk of experiencing coronary artery disease or associated interventions by 118%, and increased the risk of experiencing an overall cardiovascular event by 52%. We wanted to look locally at our data at UAB. So Sanjana, one of our research fellows, looked at the cohort at UAB, almost 4,000 patients, and showed in our cohort, and this was presented also at the AAS meeting this past year, that patients who underwent surgery had a reduction in the incidence of stroke and acute coronary artery syndrome, suggesting that parathyroidectomy may be of benefit from the cardiovascular standpoint. And plus, patients just feel better afterwards. And this is one of my patients who posted this on social media, and so I made her aware that I was going to use it in the talk as well. But this is what we see when patients are treated, and they're very grateful, and you can see it's not uncommon for them to tell us how much better they feel and how grateful they are that they were referred for surgery and then we operated on them. And again, many more. And this is why I love treating hyperparathyroidism, because patients generally do well and they feel better, and many of them thank them for changing their life. And then we get a lot of patients who are being watched but want surgery. And these are emails from patients from all over the United States and frankly all over the world that come looking because they want their hyperparathyroidism treated because they feel so poorly. All right, so that's, hopefully I've made a case of why you should consider treating hyperparathyroidism. So the second thing I want to talk about is our approach to surgery. And Jeremy alluded to this a little bit in his talk, is asking, is imaging really necessary? So as we all know, you have a lot of different choices to image the parathyroid gland, both with ultrasound, sestamibi, 4D CT, which are probably the most common parathyroid imaging techniques utilized. But sort of our philosophy in imaging is that we don't do imaging. And one is we are trying to be very cost effective. And two, patients often ask us in clinic, do I need to take another day off work to get an imaging study? Do you really need it? So Jess Fazendine, one of our former partners, and she's was visiting this week as well, actually looked at when we said, does imaging improve our results for patients with primary hyperparathyroidism? So in this cohort, we had a policy of imaging, but then we decided, all of us said, okay, all of us are going to stop imaging and see what our results are now. And so when we compared the results of patients who had imaging to those who had no imaging, our surgical success rate was exactly the same at 6 months. Obviously, with no imaging, you're going to do the unilateral operation less, but the complication rate was equivalent also without imaging. So after showing that, we all agreed to no longer image patients who present initially with hyperparathyroidism. We do image patients who have recurrent disease that are come back, but for first-time operations, we don't image anymore. So what is the best operation? So as all of you know, parathyroid surgery is the only curative treatment, and we do our surgery as an outpatient. So they come in as day surgery. We do the operation usually in an hour or less, and they go home about an hour after surgery. And our instructions to them is that not to do any heavy lifting or exercise for 3 days, but after 3 days, you can do anything you want. And virtually no patients take narcotics. So they usually take ibuprofen or Tylenol. And, you know, my experience in my career up to a few months is I've had the honor of treating over 3,000 patients this way. And generally, we use one of two approaches. One is the focus approach, which is basically based on imaging. And so occasionally a patient will present who's had imaging on the outside, and it'll be localized. And then in that case, we may consider doing a focused approach where we resect that single gland and use intraoperative PTH testing to confirm cure. But more commonly, we tend to do bilateral explorations, meaning that we identify all 4 glands and resect the enlarged ones, and generally, as I mentioned before, don't do any imaging. So we utilize clearly both techniques in our practice, and a lot of it depends on the patient. We have a lot of patients that come to us telling us exactly what operation they want. So clearly someone who we would push towards more focus is someone who's more likely to have an adenoma, high calcium, high PTH. Maybe they're on anticoagulation, so you want to minimize the dissection. And they obviously need a positive imaging study. But many times for bilateral, again, all genetic causes such as MEN1 need to have a bilateral. Patients with mild hyperparathyroidism tend to have more multi-gland disease, so we tend to do bilateral. But a lot of patients are choosing, I just want you to look at all my parathyroids to check them out, and I don't want imaging. Kim Remanel, our fellow, published this paper just explaining just our technique, because I think we're one of the few centers that utilize the radio-guided parathyroid technique. And just to explain what we do and how that happens, again, our patients are outpatients, so they come in on the day of surgery in our pre-op holding area. The technician from nuclear medicine comes with this lead vial containing 10 millicuries of sestamebe, which is half the dose that we would normally give for a scan. But we don't do a scan, that they just administer it at the bedside here. And then our nurses mark that they've been administered the sestamebe, so we know that when we bring them back to the operating room. And we use the handheld gamma probe, which is utilized for other surgeries such as sentinel node for both breast and melanoma. What we do with the probe is that we put a sterile sheath over it, and then we take a background count on the thyroid isthmus. And then this is an example of doing it. We usually do it through the skin there. And the average background count is somewhere between 2 to 500, as shown on the screen. And then the most useful thing for the probe is that then when we resect what we think is an abnormal parathyroid, we can put it on top of the probe and do what we call an ex vivo count. And if that ex vivo count is greater than 20%, so we take the ex vivo count and divide it by the background, that is definitively parathyroid tissue. So in our outpatient center, we don't really have great access to frozen section, so we never do frozen section. But we know instantaneously if it's parathyroid tissue based on that. And the screen shows actually, that's the background. This in case the percent is 200%. So clearly when the counts are over 150%, they're most likely an adenoma, such as this case. We do use PTH testing, so we use the Beckman instrument, a point of care, which sits right outside of our operating room. And we have the team draws a pre-op PTH in the pre-op area, and then we look for a 50% drop in PTH, such as in this case you can see with the patient with a single adenoma. But clearly when it doesn't drop after 5 and 10 minutes, we look for a second adenoma, and then it drops once we remove it. But typically we do the incisions through the operations with small incision, and they look pretty good. And as I mentioned, we do outpatient surgery, and we do outpatient parathyroidectomy in children as well. Similar one Andrea says for outpatient thyroid surgery, all our children go home too. Another great use of the gamma probe, and Sophie published our series on this, is that in patients with intrathyroidal parathyroids, which often many places will do a lobectomy, we will actually enucleate that parathyroid with a gamma probe. And obviously, if you enucleate it, you avoid potential hypothyroidism that can occur after a lobectomy. And then for mediastinal parathyroidectomies, we also use a radio-guided approach, which Kim Remanel described in conjunction with our thoracic colleagues. It's an example of a mediastinal parathyroid on sestamebe imaging, low in the chest. And we do a robotic approach where our surgeons go in, our thoracic surgeons go in to find the parathyroid, and we can often use the radio-guided probe to help localize it if we need to. In this case, we use the laparoscopic gamma probe, and they can almost find it with this operation. And then we're there for the reception and PTH testing. All right, so that is a summary of our operant approach. So I do want to let you know a little bit about what we're doing in the United States to help patients identify surgeons who specialize in parathyroid surgery. So what we've developed is what's called the Adult Complex Thyroid and Parathyroid Surgery Focused Practice Designation. And most surgeons in the United States are certified by their board. Endocrine surgeons by the American Board of Surgery, otolaryngologists by the American Board of Otolaryngology and Head and Neck Surgery. So our two boards got together and decided to create this focused practice designation, which is a certificate after your board designation to recognize surgeons who are going to specialize in the care of patients with thyroid and parathyroid disease, but really commit to a career that you're going to focus on learning and take care of these patients. You're going to do a high volume. So there's a volume requirement to get this additional designation and a complexity requirement. You have to show that you're doing multidisciplinary care. You're committed to continue to learn new knowledge regarding thyroid and parathyroid, and to track your outcomes versus a specialty-wide quality improvement program. And so what we did, our boards came together, and these are the surgeons representing the otolaryngology group above, co-chaired by Greg Randolph, and I had the honor of co-chairing from the American Board of Surgery side. And our steering committee got a group of surgeons together to write an exam and to do the first designation, which actually happened in January of this year. And surgeons are eligible to do this, either who have trained through the American Board of Surgery, the American Board of Otolaryngology, Head and Neck Surgery. But there's two ways you can get this additional certification. Is that you can have done it through the training pathway where you've done a fellowship, an accredited fellowship, and you had to do a number of required cases, and you have to complete this within 5 years of your fellowship. Or if you've not done a fellowship, you can do it through the practice pathway where you have to be practicing with for 3 years and document the number of index cases, including a number of complex cases as defined as shown below. And so you submit this paperwork to the board. You sit for an exam, which is a 150 question exam. In fact, we're writing the second exam right now. And what happens is that if you're in the public, you can go to your board site and you can Google any surgeon on there, and you can see their certification status, both like this is mine, I'm certified in general surgery, but I also have a focused practice designation since I passed the exam earlier this year. And so this, I think, for the first iteration, we had 100 endocrine surgeons and 100 otolaryngologists do the test this past year. And we think that this is going to continue to increase in the United States, whereby that both patients and hospitals can identify surgeons who do a lot of volume in this area. So you've seen, for those of you that are unaware, that you've seen this rhinoceros throughout my entire talk. And so you're probably thinking, why is there a Indian rhinoceros in my talk? But it's appropriate being in London here, as I think many of you know the story. The rhinoceros is a symbol of the parathyroid surgeon. And that because Sir Richard Owen identified the first parathyroid at an autopsy here at the London Zoo, and that is, as Sir Richard Owen, and the specimen is actually here in the Hunterian Museum. Vanessa actually went to it to take a picture of the actual specimen. And that is the parathyroid here, right in the small corner. So if you go to any parathyroid surgeon's office, you will see stuff like this. This is a shelf from one of my offices where I will likely buy something rhino-ish here from London too to add to the collection. All right. So last few topics I'll touch on, and Jeremy talked about this. What about normal hormonal hyperparathyroidism? And just remind you, this would be patient 2, as shown here. So we did a study, and this was by our incoming endocrine fellow, Ron Wang, who's our currently chief resident. We actually looked at our experience in patients with hypercalcemia in which the PTH was less than 50. and that we operated on. So those were 159 patients who underwent parathyroidectomy. But it's important, these patients will have a very high incidence of multi-gland disease, 60%. So you got to be prepared to do a bilateral exploration. And, but they had a similar cure rate compared to our patients who with high PTH. And they also, as I showed you in the quality of life study, they also improve with their symptoms. So what about normal calcemic hyperparathyroidism? Again, defined by patient 3, and now after excluding all secondary causes, we have operated on many, many patients with this disorder. And our series was again presented earlier this year by our former fellow Corbin Fry, who just finished. And one of the things we did specifically in this group of patients to see if they feel better or does their quality of life improve. So we have operated on a lot of patients with normal calcemic, over 500 of them. Average age was 59, about 80% were female. Obviously, the pre and post-operative calcium levels were both normal, but again, post-op slightly lower. And pre and post PTH levels, you can see were elevated before by median and in the normal range after surgery, the median. Again, a very high incidence of multi-gland disease, almost 60%, similar to normal hormonal. So again, when we operate on patients with normal calcemic hyperparathyroidism, we're always prepared to do a bilateral exploration. But what's interestingly, we did another quality of life study. This is a little different than the SF-36. It's the Qualefo 41, where a higher number is poorer quality of life. So 0 would be a great quality of life. And so we administered this survey to patients with normal calcemic hyperpara preoperatively and 2 weeks post-op. And we couldn't really believe the data when it came back, but these are the data. So you can see a lot of patients with normal calcemic have high or bad scores with pain, have problems with their activities of daily living, with their job mobility, having problems at leisure with their general health and mental function. But remarkably, 2 weeks after surgery, the average score is 0 in all of the domains except for mental function. Obviously, we want to follow this up with a longer-term study, but it was pretty impressive what it was at 2 weeks after surgery. Okay, so lastly, so where is this diagnosis forgotten? So when I first got to UAB, we did a study looking at the diagnosis of hyperparathyroid and went and looked at a group of patients with hypercalcemia. So within a 6-year or 5-year period, we looked at almost 700,000 patients who were seen at UAB, of which about half of them had a serum calcium level tested at any point in their health management during that 5-year period. Of those, 10,000 had an elevated calcium per our cutoff levels. Only 31% had a PTH tested at any time during their workup management, which really was, when we saw this and we took this to everyone, it was really, really incredible that not a single PTH was ordered in the vast majority of the patients with hypercalcemia. And when we looked at some of the reasons, sometimes they repeated the calcium multiple times until it was normal and then ignored it. Or they attributed it to some very esoteric things. So we've become Andre Gillett has developed now a method by which our EMR now signals clinicians if the calcium is high that they should consider ordering a PTH, which hopefully will work. We'll see. So lastly, I do want to end on one case, and I'll show you a video too. So this was a short-lived TV show called Chasing the Cure. It lasted for 1 season. The host was Ann Curry. And what they did is, for this show, this 90-minute live broadcast, they solicited from around the world patients who were suffering from underdiagnosed or misdiagnosed or uncured medical mysteries. And what they did is bring all the experts on TV, brought the patient on TV. So this clip is a little hard to hear.
Thank you for visiting the Chasing the Cure website. We're launching a groundbreaking new project to help people with undiagnosed illnesses. Help us solve these medical cases. You or someone you know has been struggling for some time with an illness and has gone undiagnosed. We invite you to submit your story and case file. You can participate by becoming part of our community. Write in, post, and give any perspectives that might help people find answers. Together, we're chasing the cure.
So as Ann Curry mentioned, there'd be case files up on their website where patients submitted esoteric diseases. And so you can see patients from all the United States. There happens to be one from Alabama. He had progressive weight loss, fatigue, debilitated, couldn't work. So they brought Sean Champion on TV with Ann Curry.
A malabsorption issue. Okay, that's number one. Genome sequencing, we just heard from Dr. Koo talking about looking for possible underlying genetic causes. And then you heard from your doctor physical therapy to help with your arthritis, right? That's a smart move. Yep. And then we also have a connection with an endocrinologist. We have a top subspecialist in that field. His name is Dr. Herb Chen. He's the chairman of the Department of Surgery at the University of Alabama at Birmingham, one of our collaborators. And he sent us this message for you, Sean. Take a listen.
Hey, Sean. It's Dr. Herb Chen here at the University of Alabama at Birmingham Hospital. I've become familiar with your story, and I'm excited to invite you here to the O'Neill Comprehensive Cancer Center at UAB to rule out any metabolic or hormonal reasons for your weight loss. We are really looking forward to meeting you. See you soon.
My goodness.
Wow, that's just great.
Well, I think that's a yes. I mean, yes, double thumbs. Okay. So,
I love his enthusiasm.
and that's in your home state.
It is.
That's a top doctor in Alabama.
Yes.
And then also, what about the the genome sequencing? Would you like us to
yes,
do up for that?
definitely.
Okay, so we've got a yes, definitely on all of that. Well, that's fantastic.
So this guy had been everywhere. They took him to the Mayo Clinic, Hopkins. They spent like $1 million trying to figure out what he had. And how it worked is that I knew nothing about him. I just got contacted by our media persons. Hey, would you do this video? And would you like, and I said, sure, I guess. And they wrote the script without I was supposed to read. So I read that. So I had no idea what this guy had. But I get his files, we look through it, and you know what he had? Hyperparathyroidism. So this is his post on social media. He had hyperplasia. I took out 3.5 glands, and he posted this on social media that his pain was immediately gone when he woke up. And he went back to work. Unfortunately, the show was canceled before we could go back on TV because they said I was going to be on TV, and then all of a sudden it's canceled. But in any case, so obviously this was his case stumped many people across the country. But anyway, so the disease can be forgotten by many people. I can say that we've had a great time this week, and it's been an honor to participate in your course, and I'd be glad to take any questions. Thanks.
Amazing talk. I'm sure there'll be lots of questions in the room.
So what was the cause of the weight loss in your patients?
You know, the thing is that you can see he's a little skinny, right? But he wasn't eating, and he just didn't feel well. And he was disabled at home. And so when we followed him up, obviously he felt better, at his 1 week. And then he went back to work. And I don't know, this was in 2019, so I haven't seen him for a long time. But he actively posts on the Facebook parathyroid site about how we've changed his life and stuff like that. So our follow-up has been by social media.
Thank you for an inspirational talk. Do you do many procedures under local anesthesia? Because obviously sometimes we have a lot of comorbidities in our patients.
Yeah. So when I first went into practice, I did quite a few under local anesthesia. And that was in the 2000s when we were talking about doing a lot of focus. So we were doing localizations, focus surgeries, and doing it with cervical block. Less and less patients want that, but we do it occasionally in patients who are unfit for general anesthesia. That's one time we will localize to see if we can do one, and then we'll do it under cervical block. But the vast majority of patients have general anesthesia now.
Neil.
Thank you very much for that. We, as a very experienced surgeon, and you're happy to operate without localization, and I think that's something that you acquire with time. But the patients that choose not to have localization studies are the ones that have a phobia about radiation. So what do you do in those patients, given that you use radio-guided surgery?
Well, they don't really question the radio-guided. No patient has turned down the radio-guided. And I think I'm not sure our reason for localizations is fear of the radiation, because obviously with ultrasound, there's no radiation. It's sort of the inconvenience of localization, the cost, because, insurance won't cover necessarily all the cost of an imaging study. And so there'll be some out-of-pocket cost for them. And you're right. Now, for me to say after practicing for well over 2 decades to not do localization, but like Andrea, I made her do it, and she right out of practice to make her practice that way initially. But I do think, if you don't have local, it does make you a little better surgeon because you really have to look for things and stuff like that. And then I think we're all better at identifying normal parathyroids because that's what we do more often. But I do think if you do that enough, that you'll be comfortable with it. Because I still have failures, right? I had a failure, and sure enough, it's down in the chest, but I had ruled out the entire neck, so I knew it was down in the chest.
Lovely lecture. Thank you very much. I guess John Dotman's quote of localizing a surgeon is relevant today, as it always has been, and he worked here at one stage. The question I want to ask you is that it's first of all comments about not doing any ultrasound scanning, and therefore you run the risk of missing concurrent thyroid pathology. So I'd just like you to comment on that. But the other thing I noticed, and I hope I've got this right, that when you switch from imaging to no imaging, it reduced the instance of unilateral exploration to 13%.
Correct.
If you're using a radio-labeled targeting technique while the patient is on the table, why, in view of the fact that 80% are going to be adenomas, why did it sort of tend to change your surgical approach to more of a bilateral as opposed to a unilateral approach when you're using imaging?
Great question. So if we take a normal patient, they have no imaging, we take them to the operating room, and we start on a side and we see an adenoma in the normal plan, we will consider just waiting and not exploring the other side. So there's a 50-50% will guess the right side, right? Just on guessing. I think you can also, I think some of my partners will use the ultrasound in the OR to pick a side, or you can actually use the gamma probe and just scan both sides to see which side's higher to guess an adenoma side. So we still do some unilateral surgeries, but we just don't use image to guide it. if we look at the right side, the correct side first, then we may just stay unilateral. I think we've just seen, being in practice so long, I've seen patients, recur after what you think was an adenoma with someone who really had asymmetric hyperplasia who recurs later on. And so I do think if we look at all 4 glands, there is a tendency to maybe take an additional gland that you may think is abnormal, and we scan it with a probe and stuff like that to show that. So you will end up doing more multi-gland resections if you look at both sides. But I think after doing so many, we're just very comfortable with it. And I'll make a comment on the thyroid pathology because I think that's a good one. And I had a slide on that, but I just took it out because of time. And we have a debate amongst us with our group about thyroid pathology. And such the point that I've done 2 studies on this, both at Wisconsin and one at UAB. So a study we did at Wisconsin, one of my senior partners when I first started also did not do any ultrasound imaging of parathyroid patients, just a maybe. And I looked at his patients, there were about 150 patients that he had taken care of, which we followed for 20 years. And of those 150, how many developed thyroid pathology in 20 years? 1. And there was a micro PTC that was taken out incidentally. Then we also prospectively looked at our data at UAB on patients who had a thyroid ultrasound or ultrasound before parathyroidectomy. And if you do that, you'll find about 20% have thyroid pathology. And about half those patients will get a thyroid intervention, including potentially getting their lobe out. But in our series, we've had no patients with cancer who have had a thyroid resection. So I think we way overtreat, thyroid disease in general. And we do so many unnecessary interventions based on like imaging the thyroid for parathyroid surgery. So that's my opinion. Not all of my partners agree with me. I'll just say that. But that is my opinion.
Should we take a couple of questions online? So Ryan's asking about, have you missed an intrathoracic adenoma?
Yes, yes. In fact, since this, I've missed 2. One is on a patient who had no localization. It was a 15-year-old kid that I operated on. And it turned out to be low in the chest. But initially wasn't called when we did the CT scan immediately afterwards, but we had to do venous sampling. And then that confirmed it down there. And then we had to do an MRI and they finally found it. So, and the other patient I missed on did actually had imaging beforehand, including of the chest, and it was red negative. I couldn't find anything. And then we re-imaged 6 months later and it was down in the chest. So you will miss those, but in those instances, I don't think necessarily imaging would have helped me get them the first time. So because we had to do multiple imagings to find them.
And there's another question here. So if calcium doesn't change, what is your proposed mechanism for the improved quality of life that you see in this normal calcemic?
I think that obviously there's some symptoms of calcium, but I think a lot of like muscle ache, bone pains are due to PTH. And so we know the PTH falls right away, and that could account for some of the symptoms. And I think PTH does some other things too, as well.
Excellent. Any questions, Trish? Oh, yeah.
Hello. That was very, very thought-provoking. And I've said for a while that if we invented parathyroid localization today, we'd never get the business case approved because of the benefit is so minimal against the cost. But since you've switched to a bilateral neck exploration, have you seen a difference in the distribution of solitary, double, and multiple gland disease?
Yeah, so our multi-gland disease rate is much higher because we end up seeing more glands and we end up taking them out. So I think our multi-disease, well, our single adenoma rate is not 80. It's somewhere between 60 and 70 at our institution.
It's okay. That's the same question. I was going to say, what's the proportion of single gland versus multi-gland disease, which I think you've answered.
And we say higher, and then, because based upon, because I've been in practice so long, when you're in practice so long, you get to see your recurrences and stuff. And just before I had left University of Wisconsin, we looked at a study where we tried to follow all of our patients 10 years. And what you read, in at least the surgical literature, like the cure rate is like 98, 97%, because we don't follow them long enough. We hand them off to you guys. And then, so we really tried to look at 10 years. And, the recurrence rate in our study there was like 15% at 10 years. And many of those patients had an adenoma out. And then they either had, about half of them had an adenoma, another adenoma, or half had asymmetric hyperplasia. So I do think that many of those patients who present with a single adenoma, what we think, and their PTH falls 50% in their normal calcemia at 6 months, are going to recur. So, and patients who have had this post on social media, which fuels other patients saying, oh, you got to have them look at all glands because you don't want to have this surgery again. And so that has fueled a lot of patients come in and say, just look at all my glands to make sure, because I don't want to have to do this again. And if you look, you're probably going to find something that's maybe a little abnormal. And so we end up taking those out right now. Who's to say we're doing the right thing now? We'll have to follow 15 or more years to see. But I do think we'll have a lower recurrence rate because we're a little more aggressive on the front end.
Excellent. Any last question? Otherwise, we will end this session. Thank you very much, Professor. And thank you very much for as well. Excellent. So it's lunchtime.